Hello everyone, I am Dr. Sendhil Kumar from Gateway Clinics. As everybody knows that removal of gallbladder by laparoscopy is one of the commonest procedure performed by any general surgeon or a GI surgeon. If you see, most of the gallbladders can be managed comfortably without any problem, but sometimes you come across difficult situations like acute cholecystitis, empyema gallbladder, acute and chronic cholecystitis. Then sometimes you will come across Mirizzi syndrome, perforated gallbladder, perforation with peritonitis. So many complicated gallbladders you come across on a daily basis. And one among the pathology is contracted gallbladder. There is not only contraction, there is thick wall gallbladder as well as contracted gallbladder. If you see, this is one of the most difficult surgery for any gallbladder stones diseases. Now I am going to talk about how to manage a difficult gallbladder, that is the contracted gallbladder. What are the issues in managing this contracted gallbladder? One is there is dense fibrosis and scarring of the Kyler's triangle. Then risk of bleeding and bile duct injury is more common when you manage contracted gallbladder cases. Especially if you want to dissect the Kyler's triangle, there is more chance of getting into bile duct injury or bleeding related complications. This is very common if there is any associated cholecystitis along with contracted gallbladder. If you take 100 gallbladder surgeries, this constitutes around 8 to 10% of the cases. It causes the greatest challenge for laparoscopic cholecystectomy. There is combination of inflammation, fibrosis and atrophy of the gallbladder. There is also dense scarring and fibrosis between the liver and gallbladder bed. The structures within the Kyler's triangle are difficult to identify. The cystic duct and artery cannot be identified very easily like a normal gallbladder. And if you operate in these cases, there is also a high risk of duodenal and colonic injury. Open conversion is very common and actually it involves prolonged surgery. Higher risk of associated malignancy in these cases. So you have to send all these things, study pathologically to rule out any associated malignancies. And you have to look for any contracted gallbladder, you have to look for any associated cholecystoenteric fistula. Commonest is cholecystoduodenal fistula, because in the presence of cholecystoduodenal fistula, the gallbladder will always be contracted and more chances of getting into post-operative complications, and there is more reoperations also in these cases. While managing these cases during surgery, you can use additional ports. The first step in any gallbladder, this sort of difficult gallbladder, is you should identify the gallbladder at some place. So if you identify the gallbladder without any doubt, the next step will be relatively easy, because it is very difficult to differentiate between the gallbladder and the surrounding structures like a colon and the duodenum. So without any doubt, you should identify the gallbladder wall at one location. Commonly, if you follow the liver surface under the quadrate lobe of liver, if you trace it laterally, you can normally end in the gallbladder wall. Sometimes if the quadrate lobe is covered by dense adhesions, then you can try to approach the fundus first. So any case, you try to see the gallbladder wall. Once identified, you always stay on the gallbladder wall. That is the main trick. So if you stay on the gallbladder wall, the chances of duodenal and colonic injury can be minimized. And the main issue in these contracted gallbladders are the common bile duct will be much closer than what you expect normally. That is the main point. You have to keep it in mind while doing laparoscopic cholecystectomy for this contracted gallbladder. That is the main point which you should remember while managing these contracted gallbladders, because if you don't recognize this, then there is more chance that you will mistakenly identify common bile duct as gallbladder and you will end up in major bile duct injuries. Normal anatomical landmarks like cystic lymph node, rubeus sulcus may not be seen in all the cases, so you have to be very careful again. And if there is any difficulty, instead of going and digging the scalous triangle, you can cut the gallbladder across 360-degree, cut the gallbladder across circumferentially, and from there you can look into the depth of the remaining gallbladder, whatever maybe the infundibulum or infundibulum cystic duct junction. You can see what is the left, what is remaining proximally. Then you can gradually trace it down to the cystic duct infundibulum junction. So the main idea is you have to start the procedure as subtotal cholecystectomy, and then you can convert this subtotal cholecystectomy into total cholecystectomy by dissecting the infundibulum up to the infundibulocystic duct junction, and invariably there will be a stone sitting at the infundibulum cystic duct junction. You should remove that stone which is causing the trouble, and then either you can apply endo loop or clip to the cystic duct. So this is like a modified subtotal cholecystectomy converted into a total cholecystectomy. Here the main advantage is, if you are doing a fundus first approach, you will be losing the cranial traction of the gallbladder and the liver. If you are doing a subtotal cholecystectomy, you will be leaving a remnant gallbladder. But in this case, you are actually starting a subtotal cholecystectomy, and you are doing a retrograde dissection from the level of division of the gallbladder, and you are trying to complete the gallbladder removal like a total cholecystectomy. So the advantage of retrograde cholecystectomy is there, and at the same time most of the cases you will be able to complete the gallbladder surgery as a total cholecystectomy after removal of the stone which is obstructing the cystic duct infundibulum junction. That is the main advantage. You can either use clips, loops, stitches, or some cases you can leave it without suturing also. You can do nothing and you can keep a drainage tube and come out in very difficult cases. Even if there is any bile leak in the post-operative period, unless there is distal obstruction to the bile duct, most of the time this bile leak will settle down, and only thing you have to keep the drainage tube for longer duration, at least for 2 to 3 weeks, so that the tract formation will be there and there will not be any biliary peritonitis. You can see one such case. This is a contracted gallbladder. The gallbladder size is very small, and I am telling the point again and again, the common bile duct will be much closer than what you expect normally. Whenever you see a depression on the anterior surface of the liver at the level of fundus of the gallbladder, liver will go down and it will go like that. That means whenever there is a depression on the anterior surface of the liver, you have to expect there is also anterior movement of the common bile duct, so that the gallbladder will normally, sometimes in one or two cases, it will be a centimeter or 1 to 1.5 centimeter gallbladder you can see. So this is such a small gallbladder where you can easily mistake common bile duct as gallbladder, and you can cause injuries to the common bile duct. This is another gallbladder. You can see the gallbladder is not visible, and you have to release the adhescents to identify the gallbladder wall. The commonest approach is you work along the quadrate lobe of the liver until you reach and identify the gallbladder wall. Once the gallbladder wall is identified, then you stay on the gallbladder wall so that all the adhesents along the gallbladder, like duodenal adhesents and colonic adhesents, will get automatically released so that you can do a safe cholecystectomy. I am showing one video of such case. I am actually playing it into 1.5 speed for quicker visualization. You can see the first step here is identification of one part of the gallbladder. Here we have identified the fundus of the gallbladder without any difficulty. Once the fundus of the gallbladder is identified, we are able to give cranial traction of the liver and the gallbladder with the lateral forceps, and then by staying on the gallbladder, we are releasing all the adhesents carefully and meticulously. And once it is done, then instead of going and dissecting the callous triangle directly closer to the bile duct, what we are doing here is we are dividing the gallbladder circumferentially away from the infundibulum at the level of body of the gallbladder. So, by doing this, we are able to maintain the cranial traction of the gallbladder, and once it is done, then we can remove the impacted stone from the gallbladder cystic duct junction. Then you can nicely dissect it down until you reach this infundibulocystic duct junction. Then the cystic artery is further clipped. Then we are going to apply endo loops to the infundibulum and cystic duct junction, and then the remaining gallbladder will be excised. Once this is done, then we will remove the gallbladder from the liver bed. This removal of gallbladder from the liver bed, if it is difficult, if there is dense fibrosis between the liver and gallbladder, you can leave the posterior wall of the gallbladder along with the liver, and you can just cauterize the mucosa of the leftover gallbladder wall. That also can be done. Here we have started the gallbladder surgery like a subtotal cholecystectomy, and we have proceeded till the infundibulum cystic junction. We have removed the impacted stone, and we are able to remove the gallbladder in toto. That is the advantage of this technique. In this image, you can see there is depression on the anterior surface of the liver close to the gallbladder fundus. And in this case, what we are doing is we are able to see part of the fundus of the gallbladder. So, we are using the lateral grasper to catch and lift the gallbladder cranially, and we are trying to dissect the gallbladder staying on the gallbladder wall. All these adjacents which are dense is carefully lysed until the entire gallbladder is freed. Then we try to identify certain landmarks like a cystic node or a rubeus sulcus. Sometimes it is seen if you are lucky, and sometimes if it is not seen, then instead of going and dissecting on the callous triangle, what you can do is you can move a little bit away from the callous triangle. You can divide the gallbladder circumferentially. Invariably there will be a stone sitting on the infundibulum cystic duct junction. That stone should be meticulously removed, and after removing the stone, then by using the harmonic shears, then what you can do is staying on the gallbladder wall. You know the depth of the remaining gallbladder, and you also know the thickness of the remaining gallbladder wall. With these two informations, you can dissect the gallbladder further down until you reach the cystic duct. Then you can nicely dissect the cystic duct, put an endo loop, or sometimes you can use clip also. Then in very severe cases, you can leave it alone and leave a drain and come out. Same step I am repeating again and again. This is a gallbladder. There is dense adhesions between the liver and the undersurface of diaphragm, which is carefully released. And this is not a very difficult gallbladder. This I am showing it in order for all the younger surgeons to learn the technique. So here we are not actually dissecting the callous triangle. You can appreciate the cystic node in this case. So always stay anterior to the cystic node, and instead of going and doing the dissection straight away on the callous triangle, we are actually dividing the gallbladder very well away. This video I am showing because this is the simplest video where you can learn the subtotal converting into a total cholecystectomy concept by seeing this video. Here you can see we are after dividing the gallbladder circumferentially, we could be able to dissect a plane between the cystic artery and the leftover infundibulum. There was a stone which was stuck to the infundibulum cystic duct junction that was carefully removed, and we are applying two endo loops to the cystic duct infundibulum junction. The remaining gallbladder is removed, and finally the gallbladder which is adherent to the liver is carefully removed. In difficult cases, instead of getting into complication, you can leave the gallbladder attached to the liver and you can cauterize the mucosa. In more severe cases where you could not identify any of the structures like duodenum, colon, and totally this anatomy is altered, totally the anatomy is destroyed, where we could not be able to proceed further. This patient actually had diabetes, patient was on anticoagulant treatment, patient was in sepsis. So somehow we have to intervene in these cases. So you cannot leave the patient without removing the source of infection. So in that case, you are going in and in fact what you are doing is you are actually splitting the gallbladder into two halves. One half of the gallbladder will be adherent to the liver and the other half of the gallbladder will be adherent to the duodenum and colon. And after completely removing all the stones from the gallbladder lumen, you can nicely cauterize the entire mucosa of the gallbladder, because even if you cauterize over the duodenum and colon, there is a thick gallbladder wall, it will not get conducted to the duodenum or colon. You can nicely cauterize the mucosa of the gallbladder on either side, on the liver side and on the bowel side, and you can leave a large bore drain. In these cases, even if there is any bile leak, there is no need to worry, it will get settled, and very rarely ERCP is needed, but most of the time it will settle spontaneously. So this in extreme cases, rather than going and getting into complication, a patient who is in sepsis, they can try this. This will give excellent result. Patient will be free from symptom on the next day itself. To conclude, in your practice, you will get these sort of contracted gallbladders in 8 to 10% of the cases. So to manage these complicated gallbladders, patience is the key. You have to be very patient and you should know the dissection technique, safe dissection technique, and don't do any harm to the patient if you are not confident. Rather than getting into complication, you can get help from other surgeons, and you have to stay on the gallbladder wall so that you will not be injuring the neighboring structures, and subtotal converted into a total cholecystectomy technique. Actually, if you practice, you can do the procedure safely and quickly. For that, you need some form of energy source like ultrasonic CS, or even nowadays the bipolars are available which can seal and cut. That also can be used for these cases. And in very difficult cases, rather than causing injury to the duodenum and colon, you just bisect the gallbladder, remove the stones meticulously without leaving any spilled stones. So remove the pus. The main crux of this procedure is remove all the stones meticulously, remove the pus, give thorough wash so that there will not be any infection or a stone which is left over in the subhepatic pouch and getting into late complications like abscess or sinus formation. And in case of extreme difficulty, if there is no help available, you can close and refer the patient to a higher center, so that these patients can be managed very safely without getting into complications. The one thing which you have to remember in managing these contracted gallbladders, or the one important thing which you have to remember is the common bile duct will be very close to the gallbladder fundus. The some of the cases, the gallbladder size will be 1 to 1.5 centimeters, which you have to keep it in mind while treating these complicated gallbladders. And other thing is, invariably there will be a stone which is stuck to the infundibulum cystic duct junction. You should try to remove it before completing the procedure. Thank you very much.